series. Our webinar today will discuss Oligodendroglioma, new treatments and updates in care. My name is Joanne Demas, Senior Program Manager here at the American Brain Tumor Association. I'm delighted to introduce our speaker today, Dr. Paleologos. Dr. Nina Paleologos is a neuro-oncologist at Rush University Medical Center and an investigator on multiple clinical trials, including those that led up to the FDA approval of temozolomide and benzebamide. She has done research and has written extensively on oligodendrogliomas. She was recently awarded a Career Achievement Award for exceptional expertise, knowledge, dedication, and recognition in the field of neuro-oncology by the Chicago Neurological Society. Thank you so much for joining us, Dr. Paleologos. You may now begin your presentation.
Thanks, Joanne, and thanks to all of you who are listening for attending and for your attention today. We're going to talk about oligodendroglioma, new treatments and updates in care. So first of all, we're going to go over what an oligodendroglioma is and why they're unique. Well, they're unique because of their pathology, or the way that they look when you look at them underneath a microscope. They're unique because of their epidemiology, who they affect and how they behave, both statistically in the population in general and clinically in individual patients. They're very unique in that they're very responsive to therapy, which is just great, and they're unique in their molecular makeup. They are associated, many patients with oligodendrogliomas or mixed oligo-astrocytomas, their tumor cells have deletions of pieces of chromosome called 1p and or 19q, and that's very important, as we'll learn today. They're unique in regard to the way we treat them, and they're unique in regard to that their future is bright. Okay, so let's get going here. So what I've got in front of you right now is a picture of what a low-grade oligodendroglioma looks like underneath the microscope. And if you can see here, I'm going to, hopefully my arrow works. The cells here, they look like little mini fried eggs. That's very unique to this tumor type. The little clear halo around the middle part, the nucleus, is actually a fixation artifact. It's the way that the tumor tissue is fixed for the pathologist to look at. So sometimes you don't see it as clearly as you do in this slide, but this is a very unique look. They also have these little skinny, I'm pointing to one of them, sort of thin, almost they look like chicken wire type blood vessels. So the way that they look is very unique under the microscope. Now, astrocytomas, which are a different cell type of tumor, they're very, very common compared to the oligodendroglioma. Oligodendroglioma is much rarer than astrocytoma. But sometimes tumors can have both cell types, and those are called mixed oligo-astrocytomas. So there can be cells that look like oligo cells, and there can be cells that look like astrocytic cells. This is what a low-grade astrocytoma looks like under the microscope, which we're not really going to talk about today specifically, but just to show you the difference in the way they look underneath the microscope. And on this slide, what you can see is you can see what a mixed oligo-astrocytoma looks like. It can have the behavioral characteristics of both tumors, and it can look like both tumors. And so you can see in between here, there are little cells with the halos. Those are the oligo cells I'm pointing to with the marker. And then these brown cells, they're stained brown specifically so they show up. Those are the astrocyte cells. They look like little stars. We can test the tissue for whether there are deletions of those chromosomes, the 1p19q deletions, and that can help us tell how to deal with these mixed gliomas. There are two main categories of mixed gliomas, those that have 1p and or 19q deletions, which suggests that they came originally from like an oligodendrocyte stem cell lineage, and they're more likely to behave like a pure oligodendroglioma. And then there's others that don't have the deletions, but have other types of molecular deletions like TP53 mutations, which suggests that they're going to behave more like an astrocytoma because they probably came from an astrocyte stem cell originally. So those are the two sort of main categories of mixed oligoastrocytomas. The pathology of oligodendroglioma is unique, but the grade is also unique and very important. And on this slide, on the far left, as you're looking at it, that's the low-grade tumor. The middle is kind of halfway between a high-grade tumor and a low-grade tumor. And so you can see on the far right, that's a much more aggressive, high-grade, what we call an anaplastic oligodendroglioma or a grade 3 oligodendroglioma. The reason I put the picture in the middle there is to show you that it really is sort of a transition, and it's a continuum. So you could have, and this is very important, you can have a tumor where, say you have a tumor that your doctor can only have take a biopsy from, or only part of it is able to be removed. You can have pathology like on the far left or the middle in the piece that you're looking at under the microscope, but in the middle of the tumor it might look more like this on the far right. So it'll end up behaving more like that on the far right. So you may hear me today and your doctors talk about something called sampling error. It's not really an error. It's just that if you take a biopsy of an area that looks like this, the path report might say grade 2. But yet your doctor may be talking to you as though you probably have a higher grade tumor, and that may be because of the way your scans look and the way that they may feel and suspect that other areas of your tumor look more like the two pictures on the right. So that's really more a sampling issue than an error, but that's a very important thing related to these tumors. So how do you know you have an oligodendroglioma? You can't really completely rely on the MRI scan or the CT scan appearance. You actually have to remove a piece of the tumor for analysis and study, like the pictures I just showed you. So one of the ways that can be done is through a needle biopsy called a stereotactic biopsy. The other way that can be done is through something called a resection. It's an operation to remove part of the tumor, or at least everything that the neurosurgeon can see if possible. So when we're talking about how they're unique in regards to their epidemiology and their clinical characteristics, we already mentioned they're rare. They're only 5 to 20% of all of the glial tumors, the primary brain tumors, and they arise from these specific stem cells called oligodendrogliocytes. And this is a broad range of percentages. It's probably closer to like 8 to 10% in truth, but there's a variety of studies out there with that broad range. They tend to happen in the 4th to the 6th decade of life. They're a little more common in men. Low-grade oligodendrogliomas, or LGOs, occur in slightly younger patients than that. They have a relatively indolent, slow course with a long survival time for many, many patients, especially if a patient has or started out having a low-grade glioma. I have patients that I've been taking care of with oligodendrogliomas that I've been taking care of for literally 20 years. So that's a very unique thing in comparison to patients who have pure astrocytomas. They more frequently present with seizures compared to the astrocytoma patients. Over 50% of patients will have a seizure as their first presenting symptom. And even if they don't have that, 85% will have some sort of seizure. It might be small or minor, but eventually during the course of their disease process. So seizures are really common. Other neurological symptoms are more related to the location of the tumor and the size of the tumor, sort of like real estate. It's like, where is your tumor at? If it's in a motor area, then you might have some weakness. If it's in a sensory area, you might have numbness or tingling. And we talked a little bit about the unique histology, the fried egg and the thin branching blood vessels. The neuroimaging, as we already said, is nonspecific, but there are some clues. You can see sometimes calcium on the CT scans more than the MRI scans, and that's because they tend to be slow growing in the beginning. And sometimes you'll see little teeny hemorrhages. That's from those little branching blood vessels. And you see the tumor invading the cortex, or the most superficial part of the brain, more so than the astrocytomas do. And that superficial cortex, the cortical area of the brain, is where seizures come from, which is why we think seizures are a little more common in patients who have this type of tumor compared to other types of primary brain tumors. If there's a lot of enhancement, and I'll tell you what that means in a second, but if there's a lot of it on the MRI scan, that's more typical of a higher grade, an anaplastic or an aggressive tumor. Anaplastic means the same thing as grade 3. So if you hear those words, they're interchangeable. Low-grade gliomas of any sort, including oligos, are considered grade 2 tumors, and it's a continuum. Grade 2 tumors tend to progress over time to grade 3 tumors, and like I said earlier, there can be parts of the tumor that looks more like a grade 2 under the microscope, whereas in another area it might look more like a grade 3 tumor. These really respond to treatment, and they're associated with 1p and 19q deletions. So as I said, they respond to treatment. We didn't know that until maybe about 10 years ago or so. And the reason we never knew that was because there were so few patients included in these big clinical trials that were being done. Most of the patients had astrocytoma, so they were sort of lost in the shuffle. But they are very, very chemosensitive tumors. And again, they're characterized by 1p19q loss. I thought everybody might be interested in seeing what the 1p19q deletions look like. It's a fluorescence test. It's called fluorescence in situ hybridization. We just shorten that to FISH because it's quite a mouthful to say the full thing. But basically, it's a fluorescence test that makes certain chromosomes light up. On the left, you can see you should have two copies of every chromosome in each cell. So you can see that there's 2 here of 19, and there's only 1 of the green. There's 2 of the red here and only 1 of the green. There's 2 of the red here and only 1 of the green. So this, the green represents 1p. This is a 1p deleted tumor. And on the other side, it's the exact opposite. There's 1 copy of the red here, whereas there's 2 of the green. So this is the deleted one. This is 19q is deleted on that. So that's what it looks like underneath the microscope. And that's the test your doctor is talking about when he or she talks about having or not having 1p19q deletions. Initially, years ago, when Greg Cairncross and other colleagues around the country first sort of appreciated that the malignant or high-grade or aggressive anaplastic, all those words are kind of interchangeable, oligodendrogliomas, the anaplastic oligodendrogliomas responded to a combination of chemotherapies called PCV. It was 3 drugs. The P stands for procarbazine, the C stands for CCNU, and the V stands for vincristine. But it was kind of a really eye-opening thing that these tumors, 100% of them responded to the PCV in this one series that they looked at, and then that was repeated by others later, and that patients with this tumor type had a much more prolonged survival time than patients with pure astrocytomas. Well, that made everybody go on an unbelievable hunt as to why, and that's when we discovered the 1p19q loss. Dr. David Lewis and Dr. Reifenberger, they were the ones that really first reported it, and in their biggest study, about 80 to 90% of low-grade oligos will have those deletions. About 50 to 70% of anaplastic oligos, grade 3 oligos, will have those deletions, and about half of the mixed oligo-astrocytoma patients will have those deletions. And it's not in the regular cells of your body, just the tumor cells. Tumors that look like those classic fried eggs that I showed you under the microscope, as opposed to the mixed tumors, or if they're a little atypical looking, the ones that look classical are more likely to have the deletions. And the chemosensitivity of the low-grade oligodendrogliomas is probably better predicted by the 1p19q status than any way that it looks like under the microscope. So it's a really important test. And it kind of made all of us study a bunch of things to try to see if we could tell if there were different groups. And I don't want everybody to pay too much attention to the survival data at the bottom here, because that has changed over the years, and this is old data from over a decade ago. But we really can see that there's like 4 main different groups of people, depending on if they have 1p deletion or loss versus if their 1p is intact and they have other types of mutations. And if you look, if you've got 1p loss, almost, it's not quite 100%, but almost 100% of patients will respond to chemotherapy. If you don't have 1p19q loss, it doesn't mean you won't respond to chemotherapy, though. So how does the 1p19q test help? It defines clinically relevant groups and predicts which patients will have tumors that might act more slowly or indolently, meaning that they're going to live long enough for perhaps the development of some delayed complications of radiation. We're going to talk about that a little bit later. It predicts which patients are likely to respond to chemotherapy, so that maybe we should use it earlier in those patients. So it assists us as your physicians and you as patients in deciding on what the best individual management is for your particular case. So there's lots of different treatment options, though. There's watchful waiting, meaning you don't do anything but watch very carefully with serial MRI scans, and we defer treatment until, say, the tumor progresses in size or grade or symptomatically in some way. And that may be appropriate for some low-grade tumors, but not for anaplastic or high-grade tumors. You can have surgery with a caveat, and the caveat's important. If it's technically feasible with the goal of preservation of neurological function and an acceptable level of risk. You can have radiation therapy, you can have chemotherapy. The benefits of treatment, of course, should always outweigh the risks of treatment, and the risks of not treating also have to be considered in patients that you're considering watching. So surgery, if we talk about resection, what do you get from that? Well, you get a verification of the diagnosis, and you get more tissue from a resection than you do a small biopsy, so the grading may be more accurate. There's a relief of signs and symptoms in some patients who have very large tumors where there's swelling and what we call mass effect. You get basically rid of those cells. That's what cytoreduction means. It means reducing the cell number. And in some patients, if you can do a large enough resection, that might improve outcome. It allows for a lower steroid dose. As many of you know, steroids are used to control swelling and edema, and they have their own set of side effects. So usually if you have less mass effect and a smaller tumor burden, in a sense, you can get away with either no steroids or a lower dose. We already talked about reducing sampling errors because you get a bigger piece of tissue. So it should be done if it's technically feasible with the goal of preservation of function, and as long as there's an acceptable level of risk. The extent of resection, if it's large enough, is an independent variable associated with a longer survival. So that means if you can get what we call a gross total resection, which is everything that we can see on the MRI scan is gone, or very close to it, like 80 to 90% of what we can see, or maybe slightly less than that, you will likely have an improved overall survival. But that shouldn't be done with the cost of, say, some serious neurological deficit happening. You know, if we hurt you more than we help you with the surgery, then it's not really necessarily a good thing. Some patients can even benefit from reoperation at the time of tumor recurrence. There's been a lot of technical advances that increase our ability to resect tumor from important brain, which is what eloquent means. It's very important, sophisticated brain, like our language area or motor area, with a reduced morbidity. Functional, or fMRI, can identify cortical areas of eloquent brain, and diffusion tensor imaging, or DTI, can identify white matter pathways. The gold standard, though, the absolute gold standard, is an awake craniotomy where you're actually awake and your cortex is being mapped with electrodes and stimulated, and you're participating in that resection with your neurosurgeon. Now, not everybody needs something like that, but if your tumor is in or very near eloquent brain, there are definitely some patients who might benefit from that. And it might facilitate, these things may facilitate a more complete and safer resection in patients with tumors in or near important or eloquent brain. And I just put up a couple pictures here just to show you what those things look like. On the left is a diffusion tensor imaging, and these sort of squiggly lines, those are the white matter normal pathways. And here's the tumor right here that I'm circling. And you can see that in this case, the white matter pathways are getting pushed out of the way. You wouldn't want to cut that out if, let's say, they were going through, because this is a functional MRI of a language area. Here's a language area here, and then there's some comprehensive language back here. So somebody might think if a tumor is right here in between, it's okay to remove. But these two areas are connected, and you need the diffusion image to see if the white matter pathways are going through the tumor or around the tumor. If they're going around the tumor, you might still be able to get away with operating right there. But if they're going right through, even though you're not touching each individual language area, you could have a language problem if the connecting fibers, so to speak, are disrupted. I don't have a picture of an awake craniotomy, but I know that Dr. Byrne is going to be talking about that at the family meeting in Chicago in July. So there are risks of resection, though. There's the standard risks that you see with any kind of, surgery of any sort: infection, bleeding, anesthesia complications, medical complications. Because they're operating on your brain, you can have stroke or bleeding or some sort of loss of function, which many times you have to give up a little to get a lot, but you don't want to have a large, or devastating deficit afterwards. And there's important blood vessels nearby that really play an impact into whether it is safe to operate or not. Occasionally, people will have little seizures right after their surgery just because of a little bit of inflammation there, and you can have some spinal fluid leakage as well. So once your surgery is done, whether you've had a biopsy or you've had a operation to remove part of the tumor or a resection, what do you do after that, and who should treat, and when should we treat? And the timing is controversial in patients with low-grade tumors. Most people, in fact, I think pretty much all neuro-oncologists in the country would agree that if you have an anaplastic or high-grade tumor, grade 3 tumor, that you should have treatment. Low-grade tumors, it's a little bit more controversial. But I think most of us can agree that you can probably get away with deferring or delaying treatment in a low-grade tumor after a very large or, like I said before, gross total resection, if there's minimal disease left behind that you can see on the scan, if there was no or very little enhancement, meaning the contrast dye that you have injected doesn't leak out into the tumor. If it does leak out, that's called enhancement. If there's little of that or none of that, if the seizures are well controlled and there's few or no other symptoms, you might be able to get away with deferring treatment. But you got to watch with very frequent MRI scans over time. And most people would agree that we should treat people who have grade 3 or anaplastic tumors if there's a low-grade tumor that's progressing, if there was a lot of enhancement on the preoperative MRI scan, because that would suggest that's going to behave more like an aggressive or grade 3 tumor, if there was significant size there causing mass effect, or if there are a lot of symptoms. Now, radiation therapy is kind of an old therapy. It works pretty well, though, and it significantly improves survival over doing nothing alone, or doing chemotherapy alone, or doing an operation alone in all malignant high-grade gliomas. And I put glioma in quotes here because these studies were mostly done when the oligodendrogliomas were mixed up with the astrocytomas. So there are very few studies, in fact, almost no studies, at least from back then, of oligodendrogliomas and radiation all by themselves without other tumor types being in the mix. But it became a cornerstone of therapy many years ago. There's a lot of questions I get recently about proton beam therapy because it's thought to decrease the risk to surrounding normal brain. However, I always caution people that the efficacy or the ability for it to work has never been compared to standard RT with margins around the area of abnormality. The risk with proton beam is that you can't always see the edge of the tumor, and you could undertreat the margins and then have growth right at the edge. So, it's a bit controversial, and it's never been completely tested. Stereotactic radiation is usually called things like gamma knife, cyber knife, Novalis. That's a very sort of focused, small area, high-dose radiation. It's not usually indicated in oligodendrogliomas because oligodendrogliomas are more spread out and infiltrative. The role and timing of regular standard radiation in oligodendrogliomas is evolving, especially in the low-grade tumors of any sort, but especially the oligos. The standard radiation protocol is that it's 5 days a week, not on Saturday and Sunday or major holidays, and it lasts for about 5 to 6 weeks. The initial port kind of encompasses the entire abnormality there that you can see, not on the post-contrast images, but the other images where the tumor shows up the best, and that you also include a 1 to 3 centimeter margin that looks normal around it so you don't miss any microscopic disease. And then you cone down. The radiation oncologist kind of cones down and targets the area where the dye might have been leaking out, the contrast-enhancing area, and gives a little boost to that. So the dose for a high-grade tumor is 6,000 centigrade. The dose for low-grade tumors is about 5,400 centigrade. There's a little bit of a difference, and I've got the approximates there because it depends on the size and the shape of the beam and the physics of it, but those are rough doses for the usual treatment protocol. And, there's lots and lots of studies. I've put up some that are particularly strongly related to oligodendroglioma, but we know in the anaplastic grade 3 oligodendrogliomas that it improves time to the tumor progressing. There's an improvement in survival in all types of gliomas if you give it, like, again, compared to chemotherapy alone. Chemotherapy is not necessarily worse than radiotherapy in an oligo, but I'm talking about gliomas of all types. So in any kind of glioma, it's improved over doing nothing or surgery alone or chemotherapy. Now, oligos, it's a little more controversial. In low-grade tumors, most of those studies do not look at oligodendrogliomas alone. They look at all kinds of low-grade tumors. And what we know from the bulk of the trials, the biggest one was the one I've got up here, the European Oncology Radiation study that was published in 2002, is that if you have early radiation, like right after your biopsy or right after your diagnosis, versus radiation at the time the tumor grows, that your tumor might take a little bit longer to progress. That's called time to tumor progression, or TTP. But you didn't really affect your overall survival. The trial, again, though, was not specific to oligodendrogliomas. It included all kinds of low-grade gliomas. And it also included some patients who had big surgeries and some patients who had only biopsies and had a lot of tumor left behind, and they're very different. So it's effective, but it also has delayed consequences, which we're going to talk about. So people started to wonder if there were subsets of people that maybe you should defer it or delay it. Chemotherapy, most oligodendrogliomas respond to chemotherapy, sometimes very dramatically and sometimes for very, very prolonged periods. They respond to that protocol that I talked about earlier, the procarbazine, CCNU, and vincristine, also called PCV. They also respond to something called temozolomide, the brand name of which is Temodar. The timing of when you should do it related to the radiation is still being worked out, and the length of treatment is still being worked out. With the PCV protocol, it's a little clearer because people start to have side effects of it after, about somewhere between 8 months and a year or 6 months and a year, and so you kind of have to stop. The Temodar, the TMZ, the temozolomide, that drug is a little better tolerated, and so people can stay on it for longer, and so a lot of times they will be treated for many more months than with PCV, but we really don't know what the best amount of time is. 1p19q loss really predicts response. So if you've got 1p19q loss, you have an almost 100% likelihood of responding to chemotherapy. Not quite 100%, but almost 100%. But that doesn't mean, I've had some patients say, my doctor told me I shouldn't have chemotherapy because my 1p and 19q is intact. I don't have loss. I'm not deleted. Well, that's not really true. You've just got a lower percent response rate statistically, but I've had plenty of patients, and the studies also show that many, many patients without 1p19q loss also respond to chemotherapy. This is what a low-grade oligodendroglioma looks like under the microscope here, and we've already seen that. And this is kind of what it looks like on an MRI scan. So this is the whole tumor here in white. This is the post-contrast study, and there's really no enhancement here. There's these little dark areas. Those are little cysts. Some tumors will make those. So why would you treat a low-grade? We're going to talk about low-grade treatment first, and then we'll go on to the higher-grade treatment, the higher-grade tumor treatment. Excuse me, I got a little tickle in my throat there. So why would we treat these tumors? Well, they progressively infiltrate brain. They cause increasing neurological disability over time. They cause patients symptoms like seizures, excuse me, cognitive symptoms, weakness, focal symptoms like weakness or numbness. They ultimately, over time, they progress in size and transform in grade to higher grade, or what we call anaplastic forms. Radiation is probably helpful at the time of progression. It's not so clear that it's helpful early, unless you have a lot of tumor left behind. Issues that complicate management is, that undergrading we talked about. Is it really low grade, or are you just testing that part of the tumor, and could it be a higher grade? And you don't want to undertreat people. The response is difficult to assess. These tumors tend to grow slowly when they're low grade, and they tend to respond slowly. So sometimes you give somebody chemotherapy, and you can't tell that their tumor is shrinking from scan to scan. But if you take care of them for a year, and then you kind of skip over a few of the previous scans, and you look back 6 months, you'll see that the tumor has shrunk. But you don't see it from scan to scan. The converse is true as well. When you're getting followed over time, and people are looking to make sure your tumor hasn't grown, you don't always see a subtle change in the growth. So sometimes you've got to look back a few scans to see it. The literature is what I like to call dirty, because there's like mixed tumors are included, some astrocytomas are included, so it's just not a pure literature. When you look at all the studies that are done, there's high-grade tumors that are included in some of the studies. So we still have a lot of unknowns. you know, the optimal duration of therapy, and the long-term consequences of some of the treatment. The radiation is known, but the really longer-term consequence of chemotherapy is not completely known. But now, compared to, say, 10 years ago, we know a lot more about that. And there are very few long-term consequences of chemotherapy. So we also don't know for sure, but we think that the genetic characteristics can define the diagnosis, but that's not completely proven yet. So why would we do radiation in a low-grade tumor? Well, we already know it improves the time to tumor progression, and several studies show improved survival in patients with progressing or aggressive tumors. There's no real systemic side effects to your organs like your lungs or your kidneys, and it's a very specific defined treatment time. There are a lot of studies done. Most of them are just in, you know, any kind of low-grade tumor, like I said earlier. Some of the studies show benefit, some do not. Some show benefit, but not in patients who've had gross total resections, and not in patients with really, really small tumors, seizures only, normal, you know, very indolent tumors. So it's pretty controversial. Why wouldn't we want to give radiation to a low-grade tumor? Well, there's no clear evidence of improved survival if you do it early right after surgery versus delaying it. And there's something called delayed radiation-induced neurotoxicity or delayed radiation-induced encephalopathy, where you can get, you know, problems with memory and thinking processes and an imbalance and dizziness. It doesn't happen right away, but it can happen a few years later, and it can get progressively worse, and it's a delayed effect of radiation. So one of the biggest studies showed that if you had early radiation with a low-grade tumor versus no radiation early and only when your tumor progressed, that the people who had the radiation early performed worse on the cognitive tests, that their Karnofsky score, which is a functional level, was lower. And that wasn't accounted for by, you know, how much tumor got removed or where it was or anything like that. This is what radiation encephalopathy looks like on an MRI scan. This is where the tumor was, the place that I'm circling right here. But all this up here that I'm pointing to right now, hopefully you guys can see the arrow, that's all sort of scarring or gliosis related to the radiation. This is a bad case. This is an old picture, but I wanted you to be able to actually see what it looked like. Chemotherapy risks are different. You can have, you know, suppression of your bone marrow called myelosuppression, and that can be, you know, right at the time, and it can be kind of chronic or delayed as well. There are other organ toxicities, not so much with Temodar, but with PCV for sure. So quality of life, too, can be affected because you're getting treated over months and months and months. The toxicity of the PCV protocol is pretty significant and very dose limiting. So the temozolomide is much easier to tolerate, but we really don't know how long to give it to people for. I'm going to skip over this. We really already talked about, you know, how to interpret the literature and why it's so difficult. We've already really mentioned all of this. There were a lot of low-grade studies done years ago, one of mine included, where we gave PCV to low-grade tumors, and we saw really high response rates. Then there were several more that occurred with temozolomide, and we saw good response rates. So we know that they respond. This is a patient of mine that I took care of a few years ago, and you can see this sort of hazy white abnormality all around here. That's the tumor. Part of it was removed, but all of this stuff around here was, and you didn't see it. You really could barely see it from scan to scan. So this scan was taken in July of 2003. This was taken in January of 2005, and over the course of that period of time, that patient got, I think, 20 cycles of temozolomide. You can really see the difference. You didn't see it so much from scan to scan, though. And this is an even more impressive case. This is after 21 cycles of temozolomide, so 21 months of it. Big tumor. This is the same person here, and then this is the scan after that. So you can see you can get really dramatic shrinkage, but it happens over a long period of time in the low-grade tumors. So they respond clinically, radiographically. They respond. People's symptoms can get better. That's what clinically means. Their seizures can get better. Their weakness can get better. The response occurs slowly over multiple cycles, and both drug regimens have toxicity, have activity. The temozolomide is less toxic. So it's a reasonable treatment, and a lot of times, especially if there's 1p19q deletions, that allows us to defer or delay the radiation. So a lot of times we use chemotherapy in the low-grade tumors, particularly if there are deletions of 1p and 19q. I think we pretty much went over all of this. So in the end, for the low-grade tumors, either or both are reasonable options. There's no controlled trial comparing the two of them to each other. I think the histopathology matters, whether it's low, that it's truly low grade. And I think the 1p19q is really helpful. If the 1p19q is intact, especially if it's a mixed tumor, that patient's tumor is going to probably behave in a little bit more of an aggressive manner, more like an astrocytoma, and in that case, maybe radiation might be a better choice. Now, for the high-grade tumors, the grade 3 anaplastic oligodendrogliomas, this is what they look like. They can be large. This is what we call mass effect when it's pushing like that. And then here's the white stuff leaking out. This is what enhancement looks like on your MRI scan. And you can see it doesn't do that everywhere. It's only kind of patchy. These are actual pieces of the tumor from this patient, and this was an area that was a little more lower grade, like where it looks dark, and then this was where that enhancement was. So you can see you can have a really different looking tumor in different areas. And this patient had 1p19q deletion. Years ago, there was studies of patients getting PCV, and all of those patients had already had radiation back in the day when that's the only thing we had. And Dr. Karen Cross and Dr. Van de Bent in Europe, Dr. Karen Cross in Canada, they did the initial studies, and they were all in patients who had had previous radiation therapy. This was a patient of mine that I put into one of those studies, and this was a man whose tumor came back after radiation, and this was after just one cycle. That's the tumor, and that's the improvement of the old PCV regimen. Then people started doing more creative things and doing it automatically after radiation and trying to compare it. And it looked, at least in the initial studies, that there was really no difference if you added it to the radiation versus radiation alone. And subsequent studies have actually supported that. Then we started doing it where we treated patients when they were first diagnosed, and we held off on the radiation. We deferred it. We delayed it, even though the tumors were high grade. At that time, about the largest study was one that I published with Dr. Karen Cross and Dr. McDonald, and that was 75% of the high-grade tumors responded, but 30% needed to have radiation earlier because they progressed or they had problems with the PCV. But at that time, we didn't know anything about 1p19q status. We now know that these patients were probably the ones that did not have deletions. So this is a picture of a patient who actually responded back in one of those studies. The problem is that the PCV is relatively toxic. So you can have a lot of liver toxicity, you can have nausea and vomiting and weight loss, and the suppression of the bone marrow can be tough on certain people. The vincristine, we don't even know if we need it anymore. It can cause numbness and tingling in your fingertips and toes. So it's a relatively toxic regimen. Temozolomide came along, and that was a lot easier to tolerate. It didn't cause significant organ toxicity of any sort of the kidneys or the lungs or the heart. It's really rare to affect the liver. And the effect on the bone marrow was pretty mild compared to PCV, and it didn't add up. It was not cumulative, so you could keep going. Ultimately, there were so many different ways we were treating these people that, we didn't know what to do, and they're pretty rare tumors, as we already said. So a few of us did a really large international study where we went back over the records of over 1,000 patients with the high-grade anaplastic oligos to see what happened to those patients. And ultimately, I'm not going to go through the details of the inclusion criteria, but these were not people reported in other studies. And what we learned was that, not surprisingly, patients who had the deletions did better. But surprisingly, we found that people that had deletions, some of them, a really small number, they did worse than we expected. And then we also showed that there were some patients, because we followed people for so many years, and this study went back 22 years, there were patients that didn't have deletions who did just great for decades. So we realized from this big, large study, which is the largest study ever published, that there are other factors. There are other things like the repair enzyme MGMT or a mutation called IDH. Overall, there was a trend that survival was better, actually, in patients who were treated with chemotherapy first with their radiation deferred unless their tumor progressed, and that the PCV might be a little bit more robust or give a little bit of a more durable response than the Temodar. And those are just the curves that show that. So we then also did a survey, and at that time, at least in this country, 42% of patients were being advised by their neuro-oncologist with anaplastic oligos to start out with chemotherapy alone. And at that time, the drug was temozolomide because, the PCV was too toxic. And then there were a bunch of other studies here, including the one I just went over that we published in the 1,000 patients. And overall, based on those studies, up until this last maybe couple of years, chemotherapy alone was thought to be reasonable in selected patients, usually ones with 1p19q deletions. New studies have helped us learn things, but there's no study that was really designed to answer the question of whether it's completely okay or not. There were two large, so the new data I have to give you today, there were two really large studies that came out. They compared radiation alone to radiation plus chemo. There's a study being done right now where it's radiation compared to chemo alone and then compared to both. This is ongoing. So, this is one of the studies that's combining its radiation versus radiation plus PCV. And this is the European study where everybody gets radiation and then half the patients also get PCV. Those studies were just published last year, and overall the survival in the entire group of patients was not improved by adding chemo to radiation in either one of the studies. But that doesn't really mean a lot in this age of molecular medicine because now we know about 1p19q. Both progression-free survival and overall survival was improved by adding chemotherapy in the deleted patients, but that may be because the chemotherapy is the key. Progression-free survival and overall survival was prolonged by adding PCV only in the 1p19q deleted patients in the study done in the States. And we also learned from that this IDH1 mutation is also important. Really, the bottom line here is that no study's been completed that compares chemotherapy alone to chemotherapy plus radiation. And you'd also need to look at the quality of life, not just the survival, because of the radiation-induced change. So we really still don't know completely in a big randomized study whether or not you can safely do that in every patient. Start with the chemo and then add radiation. There's just that one study that's ongoing, and there's no similar prospective randomized studies using temozolomide. That one that I already pointed out is ongoing. So there definitely are patients that are deleted that do less well than most, and there's some intact patients that do better than most, and there's other factors that play a role. We're going to talk a couple minutes about new therapies, and I think I'm running a little bit over my time. But most clinical trials that have been done in any kind of tumor are in high-grade astrocytomas. So many of the drugs used, though, may be useful in oligodendrogliomas as well. We're headed towards more targeted therapy, more specific therapies to specific proteins or receptors, and something called angiogenesis inhibitors. Angiogenesis inhibitors inhibit blood vessel growth. Blood vessel growth is associated with tumor invasion and growth and aggressiveness. So targeted therapy is basically, tumor cells make receptors for different growth factors like platelet-derived growth factor, vascular endothelial growth factor, or epidermal growth factor. And those targeted therapies aim to inhibit those growth factor receptors and their pathways, their tyrosine kinase pathways that stimulate cell growth and tumor invasion. So the agents that we're using bind to the receptors or block the growth factors themselves. And in tumors that are dependent on those pathways, the use of those agents can potentially result in tumor cell death, which is what we want. So the one that you will hear about the most and that we have the most experience is the VEGF pathway, vascular endothelial growth factor, which is in high levels in tumor that are high-grade tumors, not so much in low-grade tumors, and it stimulates blood vessel growth. There's a drug called bevacizumab. The brand name is called Avastin, which is a little easier to say. It's an antibody against that growth factor. And there's lots of studies, a couple of them I was involved in, that show that it's helpful in high-grade astrocytoma patients, but we've used it in oligodendroglioma patients. And this is a patient of mine from a few years ago that had high-grade anaplastic oligodendroglioma that had already been treated with radiation and Temodar, and his tumor came back, and this was his response. So we do learn from these other trials, even if they're not specific to oligodendrogliomas, and we know that they respond to this targeted therapy, bevacizumab or Avastin, which, as I said, is a monoclonal antibody against a vascular growth factor. So clinically, where do we go? That's the knowledge that we have up to date. So where we're going clinically is we do know now from those two big studies that just got published last year that radiation and PCV together is clearly better than radiation alone, but subsets like the patients with 1p19q deletions or patients with IDH1 mutations, there may be subsets like that where deferring or delaying the radiation until later in order to avoid radiation-related toxicity, you know, that still may be reasonable. Can we do the chemo first and delay the radiation? Phase 3 trials comparing radiation versus chemo versus both in the co-deleted patients are still ongoing and pending. But accrual's slow because there aren't that many patients in that category. Temozolomide, should it replace PCV? We don't know that. It's a lot less toxic, but there's some trend that PCV might have a little bit of a better duration of response, but it's a lot rougher of a regimen. But should we bring it back earlier in treatment, or is the toxicity still something that we should try to delay and put off? And the vincristine, I had mentioned earlier, we don't know if it really is that useful. Is it necessary, or can you use CCNU and procarbazine, the P and the C alone, each individually, or do you need them in combination? And are there targeted therapies that are more specific to oligodendroglioma than, say, astrocytoma? In regards to the genetics, where are we going? In the laboratory, we're trying to find the specific tumor suppressor gene, like what is located on the 1p19q genes. What gene is it? What's on those chromosomes that makes somebody, if you lose them and your tumor doesn't have them, why does that make your tumor really, really sensitive to chemotherapy? Or is it just an association? Is it just like a coincidence that that happens and it's really some other gene or other phenomenon that's there? Can we use the 1p19q to tell whether you've got an oligo? And if you don't have that, does that mean you don't have an oligo? We don't know that yet. We need to learn a lot more about this IDH1 mutation that was recently found and that we think is correlative to response and long-term good survival. And we need to see if there are other factors that we don't quite know about yet. I do know that the genotyping, the 1p19q, is standard diagnostic procedure now with oligodendrogliomas and has been for several years. So you should know what your 1p19q status is, and it's pretty standard to test that nowadays. I think I'm wrapping up. I'm about a minute or two over. I want to thank everybody who attended today for their time and their attention. I want to thank the ABTA for all the good work that they do. And most of all, I want to thank my patients and their families. They are the bravest people I know.
Thank you so much, Dr. Paleologos. That was wonderful. We do have some time left for some questions. So if you're open to taking some, I will pose them.
Absolutely.
Was wondering, they have the 19q deletion, but not the 1p. Could you explain that?
Yeah, I can actually. The deletion that is probably most dramatically associated with chemosensitivity is the 1p deletion, but patients who have 19q deletions, that's better than having no deletions at all in the sense of sensitivity to chemotherapy. So if the 1p is intact, you don't have a 1p deletion, but you've got a 19q deletion, still at least a third to 50% of those patients will respond to chemotherapy still.
Great. Someone's asking about 5-ALA.
5-ALA, I think that they might be mentioning it's a fluorescence compound that is used prior to resecting tumors, and it is supposed to attach to compounds within the tumor cells, but not in the normal brain cells, and then it is supposed to cause the tumor in the operating room to kind of fluoresce so that it helps the neurosurgeon see the tumor better. That is in study right now. I mean, there have been a few published reports, and it is being used in clinical trial. Still, it is not part of the standard as of yet, but it is one way that people are trying to figure out how to get the most tumor out. And, you know, the edges of these tumors, like I said before, especially the low-grade tumors, it's kind of really like thin and fluffy and microscopic, and it's like little roots from a tree. You know, you can't really see the ends of them. And so if there was a way to let the tumor cells sort of light up a little bit, that might help. And so that's what 5-ALA is for.
Sounds like some interesting things coming up.
Mm-hmm.
Can you have 1p19q and TP53 together?
Well, usually you don't. I mean, I guess there are times that there may be cases like that, but usually if you'll have a 1p19q deleted patient, then you will not have TP53 mutations too. But you know, we're still doing a lot of this work, and most patients do not have, you know, all of those molecular things tested. So depends on the institution that you're at, and you know, the level of sophistication of the laboratory there, or if they send it out someplace. You got to be a little bit careful though, because we don't always understand. I mean, the 1p19q we know a lot about, but we're still learning about it. Sure. We know a lot of stuff about the laboratory effect and the statistics around TP53, but we don't really know how we should use those results in order to direct care.
Okay, thanks. What's the significance of IDH2, and why is it different than IDH1?
Well, we're still learning that too. IDH1 and IDH2 are two different molecules. And if you have deletions, patients who have low-grade tumors and patients who have oligos are more likely to have IDH1 and or IDH2 mutations than patients who have, say, grade 4 astrocytomas, the glioblastoma patients, which is completely not what we were talking about today. IDH1 mutations and IDH2 mutations, but mostly the one, are associated with a more indolent and longer survival time. And if it's found in a high-grade patient, a patient with a really aggressive tumor, and this is better worked out in the astrocytoma tumors than it is in the oligos. So I'm really speaking more about those tumors than I am about the oligos specifically. But if you see, say, a patient with a grade 4 astrocytoma that has an IDH1 mutation, then that patient probably started out as a low-grade tumor, as opposed to a grade 4 astrocytoma who kind of popped up de novo, like it was a grade 4 from the start. So it helps us know the lineage, like where, you know, the indolent nature of the tumor, and we're still learning a lot about those mutations though. So, you know, it's associated with a longer survival time, and it's seen more often in patients whose tumors started out as low-grade tumors or who have low-grade tumors now.
Promising. This next one, I apologize, I'm not sure how to pronounce it.
Irinotecan.
Yeah, do you still use this?
You know, not as much as we did. The one slide that I showed of the bevacizumab, the Avastin response in the anaplastic oligo, that patient had also gotten irinotecan. The other name for that drug is called CPT11. It's a chemotherapy drug that was being used with Avastin a lot for years, and it's still being used. I haven't used it in a while. It tends to be pretty tough on people. It gives them a lot of diarrhea. Their blood counts, particularly the platelet count, falls pretty low. And the one randomized study we did, it wasn't really statistically powered enough to say whether adding the CPT11, the irinotecan, helped or not. But certainly when we did the study that compared Avastin alone, bevacizumab alone, to bevacizumab plus the irinotecan, the patients who got both had a lot more complications and toxicity, and so it's really kind of fallen a bit out of favor. But it's still used on occasion, especially if somebody's failed other agents.
Nice to have options out there.
Right.
What about RAD-001 to prevent growth in oligos?
Well, that's a scientific name of some company's name of something. So,
okay.
yeah.
We'll skip that one. And then the question that comes up every time I do a webinar, the role that cannabis can play as treatment for any drug that is in relation to oligos, obviously.
Well, you know, it's funny. I just actually looked at this issue because of a patient's family member who had found some things online, you know, about cannabinoid oils in cell culture. And, you know, there are some things out there, you know, online and in the literature, especially in Europe, where putting these oils into, like, cell cultures in a Petri dish have decreased their growth. I don't know what to say about that in regards to translating it to human beings. There's no study that shows that cannabis in any form, it changes somebody's survival time, prevents their tumor from growing, keeps it from growing, shrinks it, or anything like that. There are some patients, usually not very many, truthfully, especially if they're on things like Temodar, which doesn't cause a lot of nausea and vomiting, but there are some patients who have, you know, intractable nausea and vomiting who don't respond to the usual drugs, that there may be some, you know, help for symptoms, but it's not really been shown to change outcome in regards to treating the tumor itself in any sort of human being trial, in any kind of clinical trial in humans.
Okay. Again, lots of words that I am not familiar with. I apologize.
That's okay.
Wait, did we do this one? Myofolate? M-Y-S-O-L-A-T-E? Myofolate? Does that sound familiar?
You know, I'm not sure if I'm hearing you right, but it doesn't sound like. I mean, there may be somebody doing a clinical trial in it or something, but I'm not sure. I know what you're referring to.
For treating anaplastic oligo.
Well, there are a lot of clinical trials out there for new compounds, so I suspect that that person is referring to it, but you know, a specific compound where that's part of the name of the compound.
Okay.
But that one word on its own, I'm not, you know, sure. So there are a lot of clinical trials of new novel agents going on right now. Most of them are not specific to oligodendrogliomas. There are a few that are.
And that's actually a good place for me to chime in to tell people if they are looking for a clinical trial, we do have Trial Connect specialists that they can call here for, and we can connect them to and do a clinical trial search for them. So it's called Trial Connect, and they can call 877-769-4833. So a lot of these people are typing in specific manufacturers and drugs and you know, proper names like you're saying. So I would encourage any listeners to do that.
Right. I think, you know, one of the things about, you know, being asked about a specific experimental agent is that, you know, it's like, what about it? Well, it's probably being tested, but we don't know the outcome of those tests until those tests are done. So it's hard to tell somebody whether that's a promising treatment or non-promising treatment until the studies are complete.
Sure, sure. Well, we're at the top of the hour and actually 1 minute over, so I want to be able to wrap it up. And thank you, Dr. Paleologos, again. It was a wonderful information session. As always, we thank you for being such a strong supporter of ABTA. We always appreciate when you present. And this, like no other, you know, had more questions than we had time for, and this always happens. But we do look forward to you coming again this July to our patient and family conference. So we encourage people to register for that, to come and see Dr. Paleologos in person. You can register at our website at www.abta.org. I'm going to pause for just a moment to end our webinar recording.